and it is great honor for me to interview such a great personality and such a prestigious figure. Professor Qahtani, he's a well-known bariatric surgeon all over the world, not only in Middle East. You all know him very well, and especially sleeve gastrectomy. As you know better, we have started this series of interviews with the series of MGB, OAGB, and we have finished that series in June, and we had a sum up session in June. That was a great session. And then we have started this series, interview series of safe sleeve gastrectomy in July 2021. And we will continue this series till December 2021, and we will have a sum up session. And then in 2022, we will go for Roux-en-Y gastric bypass, then metabolic surgeries, and 2023, we will continue redo surgery. So sleeve gastrectomy has been started with Professor Michel Garnier. You all know better, but one of the most common bariatric surgery all over the world is sleeve gastrectomy. But unfortunately, we have faced a lot of complication after sleeve gastrectomy, as well as short and long-term complications. So this interview, why we have started these interviews, because if we see in webinar, such a legend has no time, just 5 to 10 minutes to talk, and they have no time to talk about such a topic. We need to talk because sleeve gastrectomy is not simple surgery. So if you want to do safe sleeve gastrectomy, we need such interviews, such a prestigious figures who have lot of experience, and he will share his experience, his personal experience. Sir, I will not take time. It is really great honor for me and for all of us, for GLR, for global laparoscopy and robotics. Sir, over to you, sir. Highly welcome. Sir, please, we cannot hear you, sir. Unmute.
Thank you so much, Imran. It's a pleasure to be with you and your team. And if you allow us to share the screen, to share our screen, I think you should be giving me an access. But it's a pleasure also to be with the audience of your platform. And today, definitely, we'll talk about a lot about sleeve gastrectomy, technical tips, and maybe we'll add some knowledge to everybody around us here. And we'll go a little bit of introduction, and we will be doing with you our protocol.
Sure.
Now we are, I think this is Sarah. Okay. Which one is wait, which one we are sharing? This one? Or did you? Is that one? Okay.
Sir, we can talk about your.
Do you see the slide now?
Yeah, we can see, sir.
Excellent. So we will go quickly as has been planned for us with Imran. He put some steps in the talk. So we'll go brief introduction just to show who at least I have been. And I started my practice in King Saud University and continue to be a professor of surgery. I established the obesity chair at King Saud University. Established also the multidisciplinary program at King Saud University and also at King Fahd Medical City in Riyadh. I also was the president of Aayed, which is an international endoscopic bariatric group, and also the vice president of the Pan-Arab Society of Metabolic Surgery. I did my training in McGill in Canada, Montreal. I did the American College of Surgeons and Royal College of Surgeons board. And I went back to Saudi Arabia in 2002. Then I started establishing many programs of minimally invasive with workshop and training And I was running the postgraduate program at King Saud University. We have done major reconstruction there in the program and type of accreditation and evaluations. And we continue, we have been involved significantly with Saudi Council. We established the leading program worldwide in pediatric bariatric obesity at King Saud, and we were currently we are the leading experienced person or centers in pediatric obesity. In addition to adult, we are doing a major number of cases on a daily basis. We have been involved in a lot of educational matters in terms of the media and different social media and others, mostly for educations. And we published a lot in general, in pediatric and adult, in terms of what age limit, what procedure, what suits everybody. And luckily, our publication or our experience has also changed the guidelines, especially in the younger age group. And I will just share with you some of our experience worldwide. We established the Middle East chapter as part of the IBIC. And then we published also with our colleagues in Pan-Arab Society, which is, we are happy to be from the founder members. Currently, I'm the CEO and Medical Director of Innovative Care New Medical Center, and we are continuing our practice here. The bariatric case distribution, as you can see in this slide, mostly we do sleep. I'll represent maybe 60–70% of our cases. We do revision, which is very common in our practice. I'll say maybe there is no list without a revision case. We do endoscopic, which is a very significant also portion. We do bypass. We do biliopancreatic surgery or duodenal switch. Mostly duodenal switch is in those who are regaining weight after time of bariatric surgery, after sleep mostly, or who having reflux, but they don't, it's not significant, can be managed, so we don't like to do mini bypass, or they want to have more weight loss, or mostly in those who are syndromic, like Prader-Willi, Prader-Peter, you might consider this as an option. Now, if you look to the technical step, this is sleeve 10 years after sleep, and that this case is, I've done it this week. You can see, this is, I will show you on the right side here, you can see how far we are from the pylorus. And if you look to this patient, this is after we are doing, this patient came with weight regain 10 years after sleep, and the reason he's sweet eater, and we did mini bypass. But you can see how big is the stomach. There is 10 years later, and it's almost the same as we cut it. There is no change. What does that mean technically? If you do a good sleeve, you will have very good result in the long term. What does the good sleeve means? Means you are almost 2 centimeters from the pylorus. You have very unique diameters here. Anterior and posterior wall are almost equal. There is no twist and no narrowing at the incisura, and you go in a very nice manner upward. So these are very important in the technical step of sleep. You must do it in a proper manner to avoid complication and to have a very good weight loss. Do we do pre-operative endoscopy? Not routinely. We do it on a selective basis. Symptomatic patient, yes. Patient with any GI problem. Revisional cases, almost all patients we do it based on the discussion with the patient. But banding, yes, we do it in most of them. Some of them maybe we'll do our GI study, but most patients we insist on having endoscopy pre-operative. We do it also as part of our conversion from ESG, endoscopic gastroplasty, endoscopic sleeve gastroplasty, to LSG. So these are the indication of, and this goes with the literature. If you look to the literature, the chance of having endoscopy that will change your practice is not significant. Look to this systematic review where it, or meta-analysis, which showed how many of those 10,000 patients that you will find some pathology that will push you to do alternative plan, 0.4%. 0.4 means 31% out of 10,000. So maybe it's not cost effective. However, we know there is new statement from ACMBS, and they might change the plan. But again, in general, if those who don't do it, I don't think they are at fault, and the evidence support them. Those who will do it, maybe it's better. If I'm in the government and the patient is not paying, maybe I will consider doing it because I'm not adding cost to the patient, and fair, though it's not cost effective. In the private, you have to discuss with your patient. Ideally, yes, but you have to justify this. Contraindication for sleeve patient. If you have grade C or the esophagitis, esophagus, yes. History of GI malignancy, definitely. Active gastric cancer or active ulcers that you need to manage. Uncontrolled psychiatric illnesses, drugs, of course, pregnancy, those who are really. These are general contraindications for everybody in general. But we will talk more about reflux and GERD and also LSG, whether when to do it and when not. This is another, and we also try to give you some steps and tricks and tips how to perform a good sleeve, as we, in addition to what we mentioned. What do we do with hiatal hernia in a patient with sleeve? Again, if you have a patient with GERD and you do endoscopy and there is no grade C or D and there is no paresophagus, then you will say, well, this patient, I can do sleeve. Of course, you discuss with the patient. Significant GERD, you recommend them to go for bypass. Patient with large hiatal hernia, you recommend for bypass. Now, but we know in our culture, we know in our patient, many of them say, doctor, I don't like bypass. Now, can you offer them sleeve? Yes, if they are not in the contraindication group, as I mentioned. Now, when you do sleeve in these patients who are symptomatic to start with, you look to the hiatus, there is hiatal hernia, you fix wide hiatus, you fix it, there is hiatal hernia, reduce it and fix and repair the hiatus. We repair it without mesh most of the time because it's easy to get the muscle together. If you need a mesh, definitely you put it. Though the study, a randomized study, showed there is better to do it without mesh if it's possible. So if there is no gastroesophageal reflux disease and you are intra-op, you found some hiatus, either part of the stomach going up, or there is a huge defect, or there is weakness little bit, we don't disturb the hiatus, honestly. If the stomach stay always down, the weakness is not that significant, you just leave it there. Knowing that creating more dissection will have more weak hiatus. Yes, you will repair it, but still you are balancing. If I dissect more, though there is no major hiatus defect, then maybe I'll create more problem. If there is significant defect, yes, I will fix it, even if the patient is not symptomatic. We don't repair routinely the hiatus, and we don't routinely dissect it unless there is pathology. How do we manage gastroesophageal reflux post-sleeve? Let me share with you our own experience. When we did this evaluation in our patient, 26 will have gastroesophageal reflux disease preoperatively. After surgery, we evaluate our patient and we see who were symptomatic, what is the prevalence of symptoms when we take their questionnaire. Only 26% they are symptomatic, 73 are not symptomatic. And then we went again, symptoms versus gastroscopy. So on gastroscopy, we found esophagitis 60%, grade A 16%, grade B 14%, and grade C 5%. This is on endoscopy. On symptomatic evaluation, there is no symptom of care, and there is only 26 they have the symptom. So what we conclude from this, that there is a ratio, maybe I'll see, hopefully I did not erase it. I'll just try, because I'm trying to share with you another numbers. But anyway, de novo reflux in this group was 26%, 21%. Means those who don't have gastroesophageal reflux symptoms preoperatively, 21% will develop some symptoms. symptoms post-op, but they can be managed medically, most of them, okay? And most of the patients who are not symptomatic, they will not develop symptoms afterward. Most of the patients who are symptomatic pre-op, 70% will improve post. So there are a lot of mixed experience in our practice. This is real first-hand practice. We are not saying this is real with the patients who are evaluated post-op. Some of them 3 years, 4 years, and more. So what do? We do medical management for these patients, and we'll see their improvement. If they don't improve, persistent pain, you offer them the other alternative. Mostly, if it's significant problem, we go to bypass. Significant problem, disturbing their lifestyle, they cannot live with it, they cannot be controlled with medication, we consider bypass for these patients. The other, unless they have anatomical reason, big hiatus hernia, then we say we will fix your hiatus or hiatal hernia, but it's not guaranteed you will have a solution for your problem. The best option is bypass. So that's the best option we offer our patient, but some of them will be reluctant. You give them 50% solution by fixing their hiatus. There is a big hiatal hernia also. Again, what could contribute to the problem in sleeve gastrectomy? We know these type of angles, we know the problem that could happen, but I can say the most important things here in sleeve, technically, how to run a very good sleeve, less complication. And when you finish your operating room, you understand that this patient will be doing well. And there are many patients, when you do your sleeve and you finish your operating room, you say, well, I'm worried about this patient. This sleeve is not the sleeve that I should be doing. This is very critical. And I understand, I think technical sleeve or technical tips and technical skills that we do sleeve by are the most important things in outcome of sleeve in terms of weight loss, complications, and also reflux. If we do it in a proper way, I think we will be having excellent outcome. What we recommend, as usual, we should do it 2 to 3 centimeters from the pylorus. So I always pass the tube 36 to the duodenum. And then I make sure there is a very clear symmetry of the stomach after passing the tube. So I stretch it, I spread it, I make sure it's I lay it down back on its position so it will not be pushed or twisted with the tube. This is very critical. When I balance it around the tube, and I know it's very smooth and it's not twisted and it's turned and the posterior wall and the anterior wall are almost symmetrical, then I lay it down, as I said, then I apply my staples. What I use here is either black or green, whatever available. If green, yes, it will take most of this antrum. If it is black, you can go medial on the antrum without any worry to have serosal tear. Green will give you very good transection here and stapling without serosal tear, but little bit away from the pylorus, maybe 3 centimeters or so. But you judge the tissue thickness, you close, you see how much the tissue thickness is incorporated in your grip, and you might feel it's very tough and it's very hard, then you little bit move outside. So this is green and black in J&J. If you have tri-stapler, you can use verbal black, yes, but black again, you need a 15 millimeter trocar. So I hate usually changing trocar or putting big trocars if unnecessary. I don't close the trocar at the sides. That's why I always prefer to use 12. So I go with tri-stapler purple for three loads, and I go for 10. That's for type of, because there is a question about it, that's for type of staples. In terms of J&J Ethicon, I use green and another one green, and then afterward I maybe use either directly to blue or 1 or 2 gold, depends on the available. But you can do it with the green and blue without anything in between. And if you have pleasures of having everything, you can go black, green, then you go for blue. So this is in terms of types of, but when you move from a load to another, in terms of your firing, you must again make sure your posterior and anterior are symmetrical. You don't need to twist and things. You simply make sure tissues are well. You make sure you are not too much pulling the stomach on the tube. And again, you make sure you are not too much far from the tube. So I close, I check, I move and make sure there is some room of mobility on the tube without stretching it. And again, I'm not causing narrowing at the incisura. A little bit giving it away. And again, on the angle of the last loads or fire is always either medial or on it, or medial toward the tube. So you don't leave a space, because sometimes you fire lateral, you have a gap of missing some fires or clips. And then you continue. When you are in this area, again, symmetry is very important. Not to pull too much of the anterior wall, otherwise you will be changing your stable line and will be going posteriorly. Second, you don't involve anything from the esophagus. You leave a little bit, few millimeter, maybe 3-4 millimeter of the stomach before the angle. That's my principle. You don't leave much of tissue. Why? If you leave much of tissue, it will form new fundus, and new fundus will create more reflux. New fundus will result in more weight regain. Big antrum will result in more weight regain. That's a principle that I follow. Now, the second question, so technical, I think it's very clear. And I don't, by the way, I don't put a drain. I don't test. Of course, revisional cases, that's something else. I'm talking about primary. I feed them on the same day, and I use fast track type of ERAS type of recovery. So this is in general about the technique. Then I take the stomach through the right side port, which is 12 millimeter. I widen it a little bit. I don't close the port, but I make sure I don't widen too much to create a big space. Now, a complication of sleeve. There are many complications, but I was asked also to talk about a few things. One of them leak and thrombosis and others. Thrombosis, yes, I have seen good number of cases. I would say maybe 8 or 7. I started practice in 2002. So we are talking about now almost 19 years in bariatric surgery. And I can tell you, I have seen mostly in the beginning of our practice, when we don't pay attention to ambulation, to pneumatic compression, to anticoagulant preoperatively and heparinization. So I think that's the reason we've seen few cases in the beginning. Rarely nowadays we see them. Almost I can say for the last 5 years, I don't recall I've seen a patient that in my mind now. But we gather initially almost 8 cases of this experience. Now our treatment currently, if you diagnose it, of course, how to prevent it, and this is very important, you rehydrate your patient well. You ambulate your patient well. You give them low molecular weight heparin or whatever type of anticoagulant you use preoperatively, prophylaxis. And most importantly, minimize your operative time. Minimize your operative time. Sleeve nowadays safely can be done in 30, 40 minutes maximum, very safely without problem. I know some people offer sewing. I know some people doing a lot of technical stuff. I'm not saying it's wrong or right. I'm saying yes, you can do it, but always you have to balance the benefit of doing these things on the expense of spending 1.5 hours or 1 hour in the operating room. So I think, yes, you can get excellent outcome and you can be running sleeve in a very short time in the OR. And that will pay attention, that will give you another benefit for your patient to recover without any major complication. Again, minimize some people go to 18, I go to 15. I don't increase the pressure regardless of the weight of the patient. I don't go too much of reverse Trendelenburg position, because that by itself, it's caused decreased venous retain. So it's a cumulative problem, try to avoid it. Don't you harmonic, sometimes people attributed maybe the thrombosis to creating more heat around the pancreatic areas and portal vein. That's minimize that issues. Contraceptive patient contraceptive pills, patient on smoking, heavy smoking or smoker, please pay attention to them more. Give them more maybe duration of anticoagulant post-op. Give good hydration and encourage ambulation and hydration. These are the concept of preventing this. When it is diagnosed, don't worry, but catch it early. Any patient come to your emergency room with significant pain that you cannot explain, portal vein thrombosis or bowel vessels thrombosis until proven otherwise. Send them to CT scan with all contrast. Specifically ask for this, and you have to see it yourself. Some radiologists are not familiar with this. You go and see the vessels with contrast in it to make sure it's patent. Now, and we treat them with therapeutic now. Either Clixan, you can go 80 BID, and or full heparinization if you don't have, and usually they will improve. You can send them home if they improve. The pain improve. They are not complaining of pain anymore. They can tolerate sips of water, and the bowel is moving without a lot of cramps. You know, there is bowel movement is okay. You know, there is a blood flow is okay. You can send them home and continue on the same treatment. You can do Doppler, repeated Doppler to check the patency of the vessels, or at least the flow. And even if it's not there, you continue. But the most important, you observe them clinically. There is no more recurrence of the pain. And usually it takes maybe 3 to 6 months to go back and revascularize their or recanalize their vessels, and they will be okay afterward to continue without any major problem. And this is the plan we do on our patients. They have the problem. Now we'll move to another things that we have introduced maybe since December 16, which is endoscopic gastroplasty. Currently we have 3,200 cases, and it's a procedure that we do it through the stomach directly. I'll show you some comparative between sleeve and ESG. We did the propensity score, match score for compare 11,000 patients of sleeve in our experience with 3,200. The number here is updated, and this number, the difference is almost 7. If you look, this is total body weight. And if you look to the percentage of total body weight, it's almost maybe 7 kilos or so. So 7-8 kilos at 2 years, the difference. So it is something that will help patients who are not candidates for sleeve or any bariatric surgery, or those who are overweight or obese. This is the position of ESG. So it's something from our practice. And it is, I think it will, this is where we have the total non-inferiority match between total weight and both group. We have done it in kids, and I think ESG is very suitable for kids because giving them a bridge for 2 to 3 years. And now currently we have almost 150 cases. We published the first 118 or so in the American Journal of Gastroenterology, where we follow them up to, now it's almost reaching to 3 years. But they are losing good weight, and I think it's a bridge towards, at least to give them a bridge to decide about their future. But and some of them, they will not need further management. Is it durable? Maybe up to 5 years, and we will have total weight loss. This is Reem Sharai'a from Cornell, where they follow them up to 5 years. Maybe 90% they will maintain 15 total weight loss, which is good, honestly, in non-invasive procedure like endoscopic procedure. Now, how to achieve high volume and be safe? How to run your number of cases list, good number of lists, and do be safe? I think it's very critical to go into this general principle, minimal invasive technique, as we know, standardized pre-operative, operative, and post-operative plans. This is critical. You must standardize your approach. I do it here in my clinic, like here I am today in my clinic. I have my team running. Every single thing has to be by the book. No patient go to the OR without running through all systems. No patient go without verifying all their rechecking by multiple person, their labs, their protocol, their instruction. They are aware of their management, everything. Then similarly, pre-operatively in the hospital where you do a procedure. Then post-op, there is very clear outpatient team, admission plan, follow-up plan, discharge plan, recovery. This is standard management for everybody. So this is where I will conclude here in terms of our just some sort of overview of this laparoscopic sleeve gastrectomy and some tricks and tips. Leaks, I did not go over it, but it is standard management. I will go over it. There was a slide there, but did not show, or maybe hidden. The sleeve is simple. When a patient comes with possibility of tachycardia, fever, tachypneic, pain, left shoulder pain, of course, I suspect sleeve leak. So I will go and do CT scan with oral and electric contrast. Now, if there is any leak, if there is any collection, maybe you will not see the leak, you see a collection, or you see leak and collection, or you see only leak without significant collection, means it's too early. If it is within the next 24, 48 hours of surgery, most likely it's technical. So I'll take the patient to the OR, clean everything, see what's there, and put a stent. Yes, I will suture it. It's 24, 48 hours. Still, the tissue is healthy, can be sutured. Maybe you can see how much tissue, how far is it from the incisora, and how much tissue you have, and things like that. And put a stent, and put a drain outside. That's the scenario. If it is late, little bit more than 2 to 3 days, and they are controlled, they are not too septic. The abdomen, there is no significant peritonitis. It's localized. There is collection. There is tachycardia. There is localized tenderness, but there is no peritonitis, severe significant peritonitis. You go for endoscopic management and percutaneous drainage. So I'll put a stent. We are one team. I do the stent. My team do the stent. So we have our team. I understand some colleagues, they have to call gastroenterologist, radiologist. That will delay your management. Good things in our management team. We are one team. We provide all management in our own except radiology. So we can diagnose and take the OR, put the endoscopic, with the endoscopic stent, put the drain in radiology. That is if it is a little bit late, because it's better not to disturb the whole inflammatory process that's already there. You might cause trouble down the line. If there is significant peritonitis, regardless of the presentation, you will go ahead, laparoscopic, and you do whatever necessary. Now, some cases, we elected to go for bypass, especially if the leak is big. If it's a revisional case, if it is, because we do sometimes re-sleeve, rarely we have problem, but sometimes yes. So you go for, it's not the, let us say, the ideal situation, but we do bypass to solve sometimes, to solve the leak or to cure their leak. The good things about it, especially in private, patient will not stay in the hospital for a long time. In government, you can keep the patient for, and also the quality of life, because if you keep a patient 4 to 6 weeks and maybe 2 or 3 months, 4 months back and forth in the hospital, while I can do maybe bypass, I'll go above the leak. I am not from those who leave the leak there and go and do bypass below that. I don't suggest or support this idea. I think it's better to solve it all at once. Go above the leak, do your esophageal anastomosis, whatever stomach remnant is there in the stomach, you put it up in the esophageal anastomosis, and that will help, provided you have healthy tissue, no significant peritonitis, and there is no contamination. Yes, you'll have leak, you clean it, but the tissue is still healthy. Usually that's early on. If it is late and after maybe 3 or 4 months, and I have few patients, not many, but maybe I'll say 4 or 5 or 6, that they came to me 1 year while they are having fistula leak, and I went for bypass at that time, and it works well. So these are the scenario for the leak, to how to manage it. Thank you.
Sir, thank you. Sir, please stop sharing. You can stop sharing. Click stop sharing. Sir, excellent presentation, really. And so we have a lot of questions now, because this interview overall, the theme of this interview, we ask also, you are live on Facebook and there are many viewers, and they also have some questions regarding your technique, especially for safe sleeve gastrectomy. Sir, in your presentation, you have mentioned earlier, so about 21% of your cases, because now about 2 decades you are doing sleeve gastrectomy and doing bariatric surgery, about 21% of your cases complaints GERD after sleeve gastrectomy, and from this 21%, 26% were symptomatic and 73% were asymptomatic. So what is the...
No, it is not. when you come to this number, you screen all patients. How many of the patient post-operatively will have symptoms of GERD, and how many they are not symptomatic, mean they don't have it. They are not, it's not they are documented by endoscopy and they are not symptomatic. No, it is, we gather about 700 cases follow up. I don't have the exact number, the total. Then we brought them 5 years, 3 years after surgery. Then we do the questionnaire, GERD questionnaire. And 76 or so, they are not symptomatic. They don't have symptom of GERD. We went for endoscopy regardless to check what they have. And 26%, they are symptomatic.
Okay, sir. So what is my question? Because also you have mentioned some of your patients, about 71% of your cases, they are GERD. So because they were, some of your patients, they were suffering with GERD and they had symptomatic GERD before surgery.
Yes,
After
20,
sleep.
yeah, I think there is a good number of patients who have symptoms before surgery, and more than 70%, they resolve their GERD after surgery.
Yeah, this was interesting, really.
Yes, and I think the reason, if we know obesity, one of the cause of reflux.
Yeah.
In addition to the behavior of the patient, like a lot of coffee, a lot of smoking, something augmenting their reflux. So these patients will improve after surgery. So there is a chance to improve, provided there is no anatomical reason, no hiatal hernia, no weak hiatus.
Sir, regarding head also, because some of our colleagues and also well-known surgeon, they are doing omentoplasty, because one of the issue after sleeve gastrectomy is migration of this sleeve to mediastinum. What is your opinion?
I think I don't do it, and I don't see it will help in terms of the outcome. However, there might be some benefit from others who are doing it. People believe it will prevent twisting, it will benefit flipping of the stomach, it will benefit migrating in the hiatus. I don't think so, because we know by time, this tissue, how many people come back and to do revisional surgery in a sleeve, and we know it goes back to normal. So omentum will come back and attach the stomach in place. So in the normal position of the stomach, not something you created. I feel it might create problem than helping the patient.
Sir, excellent. Sir, because now I am also practicing in Dubai, and also I know the culture of this region. So most of people, they like sleeve gastrectomy. So what is my question regarding GERD after a sleeve gastrectomy? If a patient with intractable GERD after a sleeve gastrectomy and migration, you detect migration of sleeve. So, but patient is insisting to re-sleeve because due to weight regain, also some symptoms of GERD as well. Have you any experience such a patient?
I don't. If the patient come with significant reflux and part of the stomach is up, I don't recommend, even whether primary sleeve or unless they do primary, you can consider it by repairing the hiatus, bringing the stomach down, knowing that it's not the best option for the patient. Re-sleeve or revisional for somebody with the stomach already out, little with a small hiatus or big hiatus, whatever type of hiatus, and they have significant reflux, no, don't offer receive. Bypass is the best option. Raw and white.
Excellent, excellent. Sir, regarding weight regain, so now about more than 10,000 laparoscopic sleeve gastrectomy. So we will talk also about ESG, but just now my question is about LSG, laparoscopic sleeve gastrectomy. So you did more than 10,000 cases. So what is the percentage of weight regain?
I don't have the number now, but I can get it from my data. But I will say the weight regain will be maybe around 15–20% of the statistic that we have. That's rough assumption of my cases. My management, the reason for this low number, 15–20% maximum, is because we do the sleeve in the way I showed you. I am very strict in my sleeve. I do it I don't leave big antrum, I don't leave with fundus, and so on. But we see their weight regain, and I think the most important reason for weight regain, and this is what I tell my patients when they come, whether on my own patient or refer patient to me for weight regain, I always tell them 2 reasons for your weight regain: sweet eaters and others, a type of behaviors, and big stomach. So I tell them, or maybe both. So I'll tell them, I evaluate their situation. Either we have big stomach that we need to deal with it, or you are not eating, having good behavior in your eating, and we need to deal with it. And both has to be fixed. If the stomach is small, then definitely that's your problem, is your behaviors. And then we discuss the situation. So if they are willing to change, meaning they will sweet eaters and things will change, we might consider, if the stomach is big, we'll consider 2 options. One is different 3 option or so, but in general for the stomach, because as you said, some patient will come to you and say, look, don't mention bypass, I'm coming for other option with my stomach. Do you think we can do anything? Yes, we can do. Either ESG, endoscopic sleeve gastroplasty, and we published our experience. It will give you maybe around 15% total weight loss. So if somebody 100, you lose 15 kilo. And I tell the patient, the good, it's reversible, it can be repeated, it's less invasive, and so on. The second option, if the stomach is too big or good size for re-sleeve, we could recommend also an option for if it's fusiform, it's very nice position in the stomach, the size is acceptable for re-sleeve, but it is a really like different big size in the fundus, big size in the antrum, maybe it's not good for sleeve. So depends on the anatomical shape of the stomach on X-ray or in endoscopy, and on the patient decision. Preferably, we prefer either mini bypass or Roux-en-Y bypass on those patients. So the option we discussed on the first visit after having evaluation, X-ray and others or endoscopy, is you have ESG, you have redo LSG, you have mini bypass, you have Roux-en-Y bypass. Which way to go? It is depends on a few things. One, reflux or no reflux, size of the stomach, how does it look in the endoscopy and upper GI study, patient decision and interaction with the reference, and then we decide the options and the weight to be lost. If you are expecting 30 kilogram loss or so, definitely you have to go to maybe bypass or other. If you are expecting 20 kilos or so, you go for re-sleeve and so on. But again, it will be judged based on multiple variables. Do it in your clinic.
Sir, excellent. Sir, but what's your opinion about H. pylori eradication before surgery?
We have done a study on this. Look, 70% of the specimen we send to the lab from our stomach, they have H. pylori positive. So if you have a symptomatic patient, definitely you should treat them very well. If you don't have asymptomatic patient, I don't do it routinely, and it's not recommended by literature and evidence-based to do it routine in all patients. Symptomatic, do it like upper GI upset, you do endoscopy, there is nothing, you can do biopsy and check for H. pylori, or do breath test and check for pylori. Positive, eradicate. It's not positive, and give to the protocol for 2 weeks. If it's not positive, done. If it is, there is no symptom, you don't need to look for it. That's our protocol in our area, and we don't. And if you send again your biopsy to, if the patient can post up, they have symptoms for some symptoms, send for H. pylori, and if it's positive, treat it.
Okay, sir. Sir, regarding this also, because when we discuss about GERD, so because this is the, in my opinion, and also you know better than me, all international conferences, always they discuss about Barrett and also this intractable GERD after a sleeve gastrectomy. So what is your opinion? Because now about 2 decades, you are doing a sleeve gastrectomy, and definitely you have changed your technique and the technical points for better results. So what is my question? So can you highlight that specific points? So for our youngsters, for those who are just now going to start a sleeve gastrectomy, what they must do technically to decrease the chance of GERD after a sleeve gastrectomy?
I want to share with you, if you allow me, don't know, do you see the slide now? Or
yeah, please, sir, please.
Yeah, I will show this, the slide that I already discussed it, but just to show the number. Now, you see it now, is it?
Yeah, we can see, sir.
Okay, so when you do endoscopy, some of these patients more than 5 years. I think GERD post sleeve in our area is different than other areas. In our area, it's not as common as in the West. So this is very critical, I think. Now, how many of the patients have Barrett in those patients who underwent, and there are more than 200 patients out, I think 700 total, and I think we screen, I don't the total number here that we have done endoscopy is 200. In those patients, most of them are after 5 years. And grade A, 16%, B, 14%, 5% C, and no esophagitis, though they have symptoms, by the way. 65%, they don't have evidence of esophagitis. So what does that mean is, yes, you will have patients, they have symptoms. Yes, you do endoscopy on them, but we don't see Barrett in our area. It's not common.
No,
I don't recall, honestly, I've seen Barrett, maybe not in my mind now, but on endoscopy. Endoscopy, I think, should be done on every patient and after sleep, after 5 years, if that's possible from economic point of view and cost effective. At least you follow them. We know symptoms is not sensitive. In most of the cases, literature say 40% of those who will be having endoscopic finding, they don't have symptoms. That's the numbers, maybe 38 to 40%. However, we should have it post-op, I agree, endoscopy, regardless of whether you find esophagitis or not, but Barrett is not common, at least also the dysplasia is not common.
Sir, what is my regarding this GERD? So, so regarding PPI, how long time? So you suggest your patients or prescribe PPI for your patients after the sleeve?
You mean post-op?
Post-op, yes.
Post-op, I give them 1 week BID, and I add also sacral fate for the first week. And I continue total for 6 weeks. Unless they are symptomatic afterwards, that they are taking normal diet, usual protocol adherence, and they don't have symptoms, I stop the PPI.
Okay, sir, as you have mentioned earlier in your demonstration, so smokers are also in high risk for GERD after a sleeve gastrectomy. So how you deal with these people? Because this is the common
when before surgery, I ask them to stop it. And after surgery, I ask them to stop forever. Now, however, we know our patient, they don't. I know there are protocols, but let us see practical. I hate people putting theories in online. Not people. Talking about theoretical, I take about practice. In our patients, we tell them, look, you stop before surgery, preferably as long as you can, but it's up to you. But don't smoke on the day of surgery or the day before. And this is what I tell my, after surgery, you must stop it for a long time, preferably forever. Now, what happens usually? Most patients, very few people will stop it forever. Most patients will come maybe a month later or so and they are smoking. We should do our best not to smoke in the first month and a half. The reason for that, you need to have a very good healing for the stomach, so that, and at least to protect it also with BBI and maybe sacral fate or so. I tell them, if you go back to smoking, you will have major problem. You will be having gastritis, frequent gastritis, gastroesophageal reflux, and others, and that will not be. I had one patient, he had the sleeve in another place, and he came with us maybe 5 years later. And his main problem was reflux. I did bypass RO&Y, and a month and a half later, he came with the perforated ulcer. So I said, now you are threatening your life by this behavior. We did bypass for you to avoid reflux, and you are a heavy smoker. Now you went to another direction, threatening your life with this problem. So some people never stop it. They will have problem with it. But that's the, ideally, of course, stop before surgery, stop forever after surgery. Do they do it? I'll say 90% of the patient, they don't do. They don't quit smoking. Would I say, if you don't quit, I will not do surgery for you? No, I will not say that. The reason, I'll give them a period to stop at least before surgery, to be away from their smoking, and then we will discuss later with them. But hopefully, at least they stop it forever, if not at least 1.5 months.
Sir, this, yes, I understand. And also the same thing I have faced in my practice. So now, what is my question regarding this GERD? So about 20+% of your patients are suffering with GERD after a sleeve gastrectomy. So what is your opinion about, so all of these patients were smoker, or no, which percentage of these people who were suffering with GERD after a sleeve gastrectomy were smoker? And
I'll say more. I'll say more than 30% because we try to analyze the reason under this. 30% are smoking. But the good things, it's not, as you've seen in the slide and their biopsy, it's not significant GERD, meaning they can be controlled by medical tools. Very few patients, whether my patient or referred patient, they went to, we have done Row and Y bypass for them. But most of them, they will be controlled medically with the behavioral change, minimizing caffeine intake, minimizing smoking, other issues.
Sir, it means so about 30% were yes smokers. So why I am highlighting this issue, you know better than me, because GERD after a sleeve gastrectomy is a real issue. So it means about 70%. So those were not smoker, and we have also other factors who cause GERD after a sleeve. Maybe this is due to high pressure. So what is your opinion about pyloroplasty? Have you any experience to decrease?
No, I don't think it's mandatory, and I don't think it's an ideal situation to put or to do it as pyloroplasty. I think, look, we know that GERD post sleeve is multifactorial. One definitely related to the sphincters itself, one related to the hiatus and the crura, one related to, of course, dissection around the area and disturbing the mechanism around the hiatus. One disturbing our narrowing at the incisora. When the way the anatomy of the stomach is created after sleep, how is the shape after that? Definitely caffeine is a behavior, eating behavior. Repeated vomiting after surgery, for whatever reason, by itself, it weakens the hiatus. We know that. So there are these multiple factorial, but this is why I'm saying, if you create a very good sleep, yes, we have, for example, 26% in this group, 700 or so, they have a symptomatic de novo, or 24. And that's not an easy number. It's a good number to have in your series. However, being different level of reflux and being well controlled, and maybe some of them, when you advise them to avoid the precipitating factors, caffeine, smoking, eating habits, chewing their food well, trying to, some people, they fill their stomach a lot and they vomit to get relief. Again, these are behaviors, and this is what I said, it's a lot of it. Maybe there is an anatomical reason, we have to verify it. But most of these issues can be solved by behavioral changes and also other tactics, as I mentioned.
Sir, one of the issues after sleeve gastrectomy is functional obstruction that is due to twist of a sleeve. So some of surgeons, well-known bariatric surgeon, they prefer to fix that part of stomach or a sleeve that is incisura angularis with anterior fascia of pancreas or with this base of omentum. Are you agree, or have you any experience?
I think I don't see, I'm not with or against, but I don't do it. The reason I don't do it, I always insist in having the stomach rest on its normal configurations and normal type of comfort after sleep. If you finish your sleep and you find the part of the stomach twisted, or the incisor is going up, or the symmetry, there is asymmetry, you might do some maneuvers to bring it down and straighten it. That's fair. But don't try to do it in every single patient. Always the stomach will take the best shape, and sometimes will be the opposite, will create a problem. Because when you do endoscopy, what you see from inside is not as what you see from outside. Sometimes you do endoscopy, you see the stomach without any fixation, going very nice and easily, even immediately after sleep, and there is no need to do anything. You see it from outside, it's really a little bit disfigured, and you need to correct it, but in fact, you are not correcting it. You are twisting it, because what you see from outside does not represent the lumen from inside.
Yeah. Sir, one of the main and nightmare after sleeve gastrectomy is leak. So can we decrease the chance of leak with reinforcement of stapler line?
I don't think so. And study has shown it does not. Of course, you have maybe a share in one company. You'll try to say this, but you haven't shared it. But I will tell you, I don't think so. Reinforcement, whatever reinforcement, will help in leak. And the study has shown, most of the study is not supporting this. Does it help in hemostasis? Oversewing maybe will help in hemostasis. Now, what will prevent leak or help in decreasing the chance of leak? I can tell you in our series, it's less than maybe 1 in 500 or less than that. It's very rare. But the question, I think, it is a matter how do you create the sleeve. Make sure there is no twist. Make sure there is narrowing at caesura. Make sure your anatomy is symmetrical, posterior and anterior. The stomach lying very well after you leave it. And as I said in my presentation, when you finish that sleeve and it drop, you leave it back and put it in the normal position, you know that sleeve is going to work very well for you. And sometimes you see this sleeve, you know, I will have trouble there. Yes, it happens. I mean, sometimes I tell my team, I say, do upper GI study, and this patient follow up on a high alert follow-up. Because you understand this sleeve will work well and this sleeve will not work well. So doing the sleeve in a proper way, that definitely will give you an excellent outcome in terms of leak. Again, leak is there, it's possible. We don't know 100% what is the cause, but you minimize it by technical step. And I can see everybody in us now seeing this. They understand initially in their experience, they have some more problem. Now they don't see more problem. They know it's because technically people have improved and technical maneuvers has improved, and we know what works and what doesn't work. This is why you have better outcome nowadays.
Sir, excellent. Sir, you are pioneer of sleeve gastrectomy in adolescents. One of our surgeons, Dr. Asim Shabir, he asked me to ask question regarding this sleeve in adolescents. So because now you are doing, so how much is weight regain in these and how many times you repeat surgery or re-sleeve, or you will go for any hypoabsorptive surgery in weight regain, especially in adolescents?
Okay, thanks for this question, and my regard to our friend Shabir, Dr. Shabir. Now, what we, the answer will come in the American College of Surgeons, Journal of the American College of Surgeons, maybe in less than a month. And we have 10 years follow-up of pediatric and adolescent patients. And we have up to 71% at 10 years, excess weight loss. So the weight loss is significant. And I see, I don't know, maybe it's different scenarios here, because it could be their compliance is better. It could be they are getting their self-image and they're improving and they're happy with their what we reach and they maintain their weight. So they are, if not the same, they are better than adults.
Okay, sir. Really, thanks. Sir, have you any video to share for your technique, or we can go ahead?
I have a video, but it's long, and this is why I elected not to show it. I can show you some clip if you want.
Okay, sir, please.
Let me see, hopefully, Sarah, where is the... Did I stop sharing? Yes, I stopped. Okay, I'll go back to, where is the video, Sarah, that Ahmadi made initially? I deleted, I think, do you know? The one I did it, huh? Where did you put it? Huh? In this, in the folder. Yeah. Undiscovered.
Because sir, most of our viewers, they are youngsters, and also they like to know tips and tricks, because sleeve gastrectomy is not simple surgery. There are technical points, and if you as you have mentioned earlier, so with the passage of time we can decrease chance of complications. If we go standard sleeve gastrectomy, there is less chance of complications like leak, like GERD, like weight regain. So this is very important. So these technical
absolutely
patient selection, MDT, that you have, and follow-up, proper follow-up of these patients, definite. So sleeve is a good surgery. Sleeve is one of the most common bariatric surgery in this globe. So we can achieve better results with follow-up of these tips and tricks. Sir, we cannot hear you. Sir, you can unmute yourself. Sir, unmute yourself. Unmute yourself.
deliberately I'm muted, and now I will unmute. So I'll try to share with you now a video.
Okay, sir.
Now it's working. How is it? It's doing. So this is
Yeah.
I will run it a little bit fast because it's a little bit long. But anyway, I start here usually. I use ligature or harmonic. I continue upwards. This is, by the way, this is sleeve post ESG.
Yeah.
This patient has ESG. So you see some adhesion on the posterior wall. That's expected because of ESG. Post endoscopic gastroplasty.
Yeah. This is
So,
gastroplasty.
Yeah, post endoscopic gastroplasty. So I go endoscopic first.
Yes.
I go endoscopic first. I remove all suture, and then I start. I go laparoscopic. I free everything, and then what I do, I block the duodenum, and then I do endoscopy, and then I remove all type of suture inside the stomach. Then I do ASC. So if you have the history, if you have this, you can see I position the stomach straight. You see the tube here. There is anterior posterior wall, well positioned. How far? See how far I am from the pylorus? Not much.
Yeah.
Again, here I am using tri-stapler, and I go parallel to this. And when you see the sleeve afterward, you understand it. I try to. This is a little bit away because I have maybe I'll call it another. This is the final sleeve. You'll see. Sorry, this is the final sleeve. You will see it this way. Now, and we remove the tube. You will see the stomach taking the normal position with this. Little bit away from the pylorus and going on the tube. That's the sleeve that we expect to see. This is just a small clip. I'm sorry the video is not well edited for you, but I just asked my team to prepare it quickly.
Sir, excellent. Sir, yeah.
Yes.
Sir, excellent. So definite. So this is because you did for the patient ESG, and due to weight regain, again you go for LSG. So
yes.
What is my question regarding this? So when we do a restrictive procedure and we repeat again restrictive procedure, there is less chance of that result at weight, achieving that weight loss after any restrictive procedure. So during in bracket, I have a question, because when we do after sleeve gastrectomy, mini gastric bypass or Roux-en-Y gastric bypass, then we have no access to duodenum with endoscope. If patient will suffer in future with CBD stone, or we want to do any endoscopic access, we have no chance to access to duodenum after such a surgery, because in primary Roux-en-Y or MGB, OAGB, we have a remnant stomach and we can access to duodenum from remnant. But after a sleeve gastrectomy in redo surgery, when we do Roux-en-Y or OAGB or MGB, we have no access. What is your opinion about SASI? If you go for SASI in such a case, so 250 common channel, yes, we will achieve the target of weight loss, as well as we have access to duodenum. Have you any experience?
I will tell you, SASI, I don't do it. And I do duodenal switch, which is almost, as you know, not like SASI, but in general, your question about restrictive and restrictive. I don't see a sleeve as a restrictive procedure. Sleeve has been shown, it is definitely restrictive, but also metabolic procedure. And this has been documented by changing ghrelin, changing other factors, changing BBOI, changing all these factors. So definitely it's not any more restrictive. It is metabolic and restrictive procedure. In terms of what I think the best scenario, what I recommend for my patients, they don't have reflux. Mini bypass is very good option. The chance of requiring to do duodenum, I agree, but there are a lot of ways to do it. I mean, you can do it laparoscopic, endoscopic assisted. You can do it if you need to do access like common bile duct stone or stenting or other, or you can do transhepatic. There are a lot of ways to access the stomach by whatever tools. Considering it's very rare, you cannot make your judgment for bariatric surgery on something that might not happen in, or you might not need it, maybe 1%, 10% in cases. So why should you change? No, go to what can give you the best outcome. We know mini bypass will give you an excellent outcome, considering as weight loss and resolution of comorbidity compared to Roux and White bypass. So that's for sure. We know SADI can give you, again, excellent outcome. However, you might have more complication in terms of steatorrhea compared with others. Maybe it's less than, definitely it's more than mini bypass, but mini bypass has its own percentage. Protein, calcium, and others, and in mini bypass, we don't pay attention to it. So I think balancing it, but nowadays in our community, at least in our area, and you know that, Imran, and you are one of those who are excellent in doing these procedures, mini bypass has been really growing as the alternative and the best scenarios with that you can offer somebody with weight regain after sleep, especially if they don't have reflux. So this is the best scenario, and this is what I offer my patient, and I think it's the best option. SADI, we can offer it for those who are really having, again, maybe mild reflux or no significant reflux, but the most important, they would like to lose more weight, or they are syndromic.
Sir, really so much thanks, because now more than 1 hour, so we have started this interview, and really it was very fruitful and also practical discussion, because we need such a discussion. Our youngsters need such a discussion, because now this was really lucky, we all of us, and it was great opportunity to have such a prestigious figure who has shared his own experience. Sir, so much thanks. Or any message for our youngsters who are just now going to start sleeve gastrectomy?
Yes, the message, thank you so much, first of all, Imran, and thanks for your team and everybody. And thanks for the people who are joining us today. The message, please learn things in the proper way and learn from the best experienced person in your area or any area. This is, don't try to learn it on your own. You will never learn it. You'll spend a lot of time. Your learning curve will take longer time. You can shorten your learning curve by learning from somebody who's doing this procedure. Mentorship is critically important in these cases. Knowing what's wrong. Look, many people have learned the hard way, and then they have a lot of problems. And many people learn it the easiest way by learning from somebody. You are gathering other people's experience to benefit you in your learning curve. So this is the best scenario. Again, joy in science by reading, understanding, reviewing literature, knowing your patient. I always put 3 circles about every single patient. The first circle is pre-operative evaluation. You are a physician, you are not a technician. Don't go and don't think about your patient and do your procedure only on the operating room. You are a physician to evaluate your patient better even than anybody else, better even than a cardiologist or family physician or endocrinologist. I sometimes resend the patient to cardiology because of problem that I recognize. So pay attention to medical part of your patient. Prepare them very well and do your surgery. Intra-op, you are not only a technician, I prepare, and you should be looking for, and my team, they know that. I look after every single aspect of my patient, from the anesthesia medication to pre-operative evaluation and to entering the room, to recovery room, to going to the floor. This is a circle must be complete. The second circle is the OR. OR also your business. You don't do your surgery and finish, you do the skin and you go in the waiting area for the next case. I think it's your choice, but this is not, especially the junior person. You stay with your patient, you know what's going on with your patient, you know what is the management, you supervise the management, you know the wrong things and the right things, and you do it. But again, that needs a knowledge from all these things. You cannot interfere with the anesthetist if you don't know what are these medications and how do they work and this and that. Similarly, post-op. Post-op, you be on top of everything. You have a protocol and clinical pathway. You must make sure your patient through a protocol, not a judgment on each patient. No, every single patient must be evaluated for this before discharge. And then the follow-up, there must be a protocol for follow-up. So these are ways to have a better outcome and avoid complication, and good luck for everybody.
Sir, so much thank you. It was great message, and personally I have learned a lot during this interview. Really my best wishes are for you, your team, and You are a great asset for our bariatric world, in my opinion. It was great interview, and so much thanks our viewers. So till this time, because I know in Asia and India now this is the late time, and also my colleagues who are watching from Europe, so much thanks to follow, and please follow. Next week we will be with another legend of bariatric surgery. So please continue your sport, because without your sport we cannot continue such a series. If you have any question, you can ask personally from me, and also from comment. Professor will also available to answer your questions. Sir, so much thanks and have a nice time.
Thank you.
Thank you, sir. Thank
Bye.
you. So